The views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of Bronxnet or the program underwriters.
Welcome to Public Health America, a weekly program produced by Bronxnet in partnership with Mercy College. I'm your host, Dr. William Latimer. Here on Public Health America, we speak with experts from an array of specialties across the liberal arts and health professions to provide you with not only the best science, but practical tips to live a healthier life. We also celebrate what studies have long documented, namely the unparalleled value of a liberal arts college education by setting the stage to pursue a career of your choice, increase lifetime earnings, and engage in civil debate. Our experts will share decisions they made and support they received that helped them to beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. It is a pleasure to invite Dr. Tashuna Albritton, Assistant Medical Professor at the City University of New York, School of Medicine, Department of Community Health and Social Medicine. Tashuna, welcome to the program.
Thank you so much for having me.
You're very welcome. It's great to have you here. So I know you've been doing some cutting edge work on HIV rates in the United States, and particularly among Black adolescents, to understand barriers to HIV prevention and how to best prevent HIV in this population. Set the table for us. So tell us a little bit about your work.
Yeah, sure. So I think what the public needs to know is according to the latest Center for Disease Control and Prevention, or what we know as the CDC, is that for adolescents between the ages of 13 and 24 years old, that more than 50% of the annual HIV diagnoses are among Black youth. And as of 2017, persons ages 13 to 24 years old that have been diagnosed with HIV, of the age group, 52% were Black and 25% identified as Hispanic or Latino, and 18% identified as white. And so we can see from both of those statistics that Black or African American youth disproportionately represent the new diagnosis of HIV annually in this country. And so from that perspective, and that has been a trend, I would say, for the last 20 years in this country. And so, and we know that these disparities also exist in Black adults in this country as well. So this kind of begs the question as to kind of what is happening in communities of color, particularly in Black communities, and why this trend is persistent among Blacks and particularly among Black adolescents in this country.
That's exceedingly alarming. So you're saying, so if I get the numbers off a bit, forgive me or let me know. So African-American rates 50%, Hispanic, Latinx 25%. That's 75% of the cases. I mean, African-Americans in the U.S., what, 15%? What?
Yeah, Blacks represent around 13% of the population in the U.S. And so, I mean, these disparities are, it makes you wonder, like, what is happening? And because, like I said earlier, it's a persistent trend.
Right.
So so one must think beyond individual behaviors. There's something else going on that's larger here.
Got it. Mm-hmm. So you've just helped me with my next question. so it's bigger than individual behavior. So we're looking at structural, societal type factors, perhaps. What are some of the things that you're looking at? What are the current explanations, and have those explanations evolved over time, or is it the same 3 or 4 factors, or a little bit of both? If that's a fair question.
Yeah, that is a fair question. So I would say that in terms of looking at interventions or prevention research around HIV, I would say in the earlier years of looking at HIV with adult populations, and then eventually a focus on younger populations, adolescents and young adults, it was a focus on individual risk behavior, right? And then I would say probably in the 2000s is when we start to see structural level interventions come onto the scene. And when I mean structural level interventions, that could be policies that are in place that impacts access to care, and some kind of broadly sexual reproductive health policies in specific states around when adolescents can actually get access to sexual reproductive health services and care without parental consent, things of that nature. So it has been an evolution from individual risk behavior, prevention, intervention research to now looking more broadly at structural factors that need to be modified in order to increase access to quality care and prevention services for adolescents.
Makes a lot of sense. I guess where I feel or think I'm a little daunted. I'm now old enough that I've heard the call for the need of greater access for a variety of reasons, all of them good. And certainly the Bronx, as exceptional a borough as it is, the best in NYC, it has its share of health inequities and health problems. How do we really, in a concrete way, move the needle to accomplish the very excellent aims you just outlined?
Right. I think part of the issue for urban and rural communities is, if we're honest, kind of the historical experience that Black and Brown people have had in the healthcare system, which has not always been in the best interest of people of color in the healthcare system in general. And so, for example, in the Bronx, there could be, there are a couple of clinics that target adolescent and sexual reproductive health. But, when we're thinking about, centuries of mistreatment of people of color in medicine, one is not always eager to go and go into the healthcare system, and for younger populations, it can be difficult to know how to navigate the healthcare system. And so, but to my point of kind of the quality of care and the experiences that adolescents and people of color have in the healthcare system, it is the feeling of, does my provider really care about me? Is my provider kind of giving me kind of the latest kind of medical information that would be most beneficial for someone like myself? Can I trust this person? So it's kind of the overall perception of, does my provider care for me? Is this someone that I can relate to? Because in particular with younger populations, if they feel like the adult, in this case, who's the provider, is not someone who has their best interests at heart, they're not gonna protect their confidentiality or privacy, which is paramount in medicine. Why should I engage? Is this information going to get back to my parents that I was in this setting and that I made certain requests? It is the fact of what is the experience with people of color in the healthcare system, but particularly those additional barriers for younger people who want to exercise an autonomy around their sexual reproductive health, but there's this fear factor as well.
Sure. I mean, those are complex and difficult challenges to face. So some of the thoughts that come to mind are, are we intervening at the level of training the doctors of the next generation to sort of have a greater chance of having the qualities and skills, empathy, awareness of, et cetera, that you just nicely outlined, or is it, trying to get, which I know there are movements to do this, but, I don't know the numbers, trying to get more, students of color to enter the health professions, medical doctors, nurses, et cetera. I've been involved with some of those initiatives myself, including some right now. But what are the areas of intervention that you see or that you're working on to try to have a workforce that has the skill sets you just outlined?
Yeah. So all of the points that you just mentioned are things that are kind of in motion. For one, increasing and diversifying the healthcare workforce. That has been, I would say, for the last maybe 15 years, trying to really increase persons of color, whether they be physicians, nurse practitioners, nurses, folks who would definitely have a direct impact on care on a daily basis, increasing the workforce from that perspective. And so, and in some states, there are different initiatives to, for example, paying for one's student loans to attract, underrepresented minorities in certain health professions, or in particular, other options are, to attract people to go into rural communities who are also people of color, kind of compensating financially. So yes, building up the workforce and diverse workforce is one perspective. In terms of current providers and building up, I guess, a sensitivity has been the idea of introducing implicit or unconscious bias training in medical schools or schools of public health for future practitioners to think about things that when we say unconscious bias, we're implying the fact that people are really not cognizant that they are engaging in biased behavior. And so basically bringing that to one's attention so that they can be more aware of the engagement and kind of basically self-correct themselves if they are thinking in a biased manner. And there's also trainings, and some of these trainings are online for in pediatric medicine, and also I think just in internal medicine in general, of how to do a more comprehensive sexual history taking with adolescents and also with adult patients as well, so that conversation is more comprehensive. And providers for decades have expressed a general discomfort in taking sexual history taking with their patients, but particularly with younger populations. And so there are some, I would say, some interventions that have been put into place, but all of this is still a work in progress.
Sure. Well, you just outlined, I think a really excellent set of aims to probably take us through the next decade, but that was very precise and extremely helpful. We're going to take a quick break. When we come back, Dr. Tashuna Albritton will tell us a little bit about her personal journey and how higher education helped set the stage for the excellent career that she currently has in research and practice at the City University of New York. This is Public Health America. I'm your host, Dr. William Latimer. We'll be right back. Welcome back to Public Health America. I'm your host, Dr. William Latimer. So I'm here with Dr. Tashuna Albritton, Assistant Medical Professor at the City University of New York School of Medicine. Tashuna, so at this segment of our program, I always begin with the same question. Where were you born? And tell us a little bit about your formative experiences.
Sure. So I was born in North Carolina, in a small town called Tarboro, North Carolina. But I'm actually from a smaller town called Hamilton, North Carolina, which is in the eastern part of the state. And so it's a region that is very rural, low density in population. I would say there was not a lot of opportunities, and there still isn't a lot of opportunities for young folks. It's a pretty stagnant region. It's primarily agricultural. A lot of the factory jobs that were there in the 70s and 80s went overseas. And so a lot of people moved from the community to larger cities outside of that region for better jobs and for better opportunities. So for someone like me, education had to be the key in terms of having a future that would provide me with the opportunity to basically financially support myself and a family.
So we've had a wide range of guests from a wide range of backgrounds. We've had one or two, but not too many from rural backgrounds. So it's very interesting and helpful to sort of hear that summary. Did you go to public school, private school, and ultimately where did you end up going to college for your undergrad?
Yeah, sure. So I went to public school from kindergarten to 12th grade. And these were, obviously, these were very small schools, not a lot of diversity. You were either considered Black or white, not a lot of diversity and in religious backgrounds. There just wasn't a lot of diversity. And so these were schools that were surrounded by corn and cotton and tobacco fields. When I say rural, I really mean rural. And so upon graduating from high school, I went directly to college. In my family, you had that my family said that you'd have to go to, get a job, go to school, or go to the military. So I was inclined to go to college. I did well in school. So college for me was always an aim for me. It was never something that I never, considered doing. Because I just knew over the years that was just kind of the way to go to kind of progress and advance. So I attended the University of North Carolina at Chapel Hill, North Carolina, which is like from where I grew up, about 2 hours away. And that was a completely different world. I found it mind-boggling that Chapel Hill was only 2 hours away from where I grew up, but it was such a different environment. Just the diversity alone was a bit overwhelming for me. But it was a challenge because I came from schools that had very, small numbers in terms of students. My entire high school, not just the senior class, was like 500 people, across 9th to 12th grade. And so entering a major state university that had like somewhere between 30 to 40,000 students at that time was just overwhelming. And I really had to kind of struggle and kind of fight my way through being in, particularly the first and my freshman and sophomore years, some of those, what we consider general college courses or courses that you had to take to meet certain requirements. I could have had 400 people in one class. And coming from such a rural community and small school settings, that felt very intimidating to me.
Sure. I could see, that makes complete sense. And let's also say UNC Chapel Hill is one of the best national public universities in the country. So you were at a really, really great place. And obviously you must have been competitive to be accepted. And then, you had a completely different experience, given that you had come from a rural area. What was your major, and what were some key experiences during undergraduate of any ilk that were formative?
Yeah, sure. So I entered in as a pre-med major, and I would say in the first academic year, I realized that I really didn't want to spend my time studying biology and chemistry and physics. And I realized that really that wasn't my strength, that I was more of kind of a social, kind of behavioral science person. I was drawn to social sciences and humanities. And plus, I just wasn't doing too well in what we consider the life sciences or physical sciences classes. And I just figured I have to have a commitment to spend extra time studying for these classes, but I just didn't find them interesting. I like the idea of being a physician. I like the idea of helping communities and individuals. But, there's a preparation to actually get to the point of being a physician. And that is to study like those core science classes that, if I was honest with myself, that I just wasn't willing to commit those time. And I was going to gravitate towards courses that really interested me. And so I end up doing a double major in psychology and African American studies. But it was not, in my head, I'd always planned to go into medicine. My mom was a registered nurse. And so I kind of felt like, I was kind of accustomed to kind of hearing about like the hospital kind of lifestyle. And it just all seemed interesting to me. And I did have a sincere passion for it. But I also knew that, those courses just weren't my strength. And to make a transition from pre-med to another major didn't mean that I was a failure, but it did take some mental processing for me to say, okay, I'm going to pivot and do something that's really different than what I've been saying for the last, several years, to do something that really interests me, and that I knew I was going to spend the next, 3 years of college really studying in those classes and not feeling like it was a burden, but more of a chore. More of a joy, to study in these fields and disciplines.
Yeah, no, I think that's an incredibly important life lesson, that you went into a really great college thinking that you would do one thing, and then were fortunate to realize relatively early in your, if you will, academic career, that your passion was in a different field, and then ended up double majoring in that. So I think that's fantastic. It's just to let our audience know it's important to, have a vision and a mission, but it can evolve and change over time. And clearly you did that. Was there, once you made that switch and, sort of found the double major that was something that was joyful to engage in, Was there a key mentor? Were there experiential learning opportunities? What were the aspects of those majors and experiences that you gravitated to the most?
Yeah. So I would say that in terms of psychology, I ended up working in someone's lab. And it was more around kind of cognitive psychology and experimental psychology, a little bit of mix of that. And she was such a great mentor. She was very hands-on. Um, Primarily in her lab were doctoral students or postdoctoral fellows. And I was this, undergrad who was, trying to learn and kind of find my way. But I found her to be very gentle, again, hands-on. I didn't feel like a burden. And I think for a lot of underrepresented minority students who are in predominantly white institutions, which is UNC is a predominantly white institution, it can be difficult to kind of integrate into labs or other networks where in most cases the professor is not a person of color, to really feel welcome and to see them really invested in your learning. So that was a really kind of important time for me from that perspective. In African American studies, they were most of my well, I'll take that back. It was probably a mix of faculty members in the department at that time. Some were Black and some were white, but there were a few who I think just inspired me because of their kind of passion that they presented in the classroom. And so those were kind of really memorable moments. I never before going to college, remember kind of studying literature or any kind of major historical events that were specific to Blacks or Black Americans. And just to kind of see that passion display from those faculty members in class and really encouraging students to not think about Black studies or African American studies as a just for Blacks, that it is a part of American history and U.S. history. So that was, for me, life-changing because I just never had that experience of kind of being immersed and kind of with Black intellectual thought, Black intellectual literature that I had to read. It was just a different experience. And so I really embraced it. And I also found it very rewarding because, again, I'm in a predominantly white setting. And so to have this kind of meet me at the core of who I am as an individual was very meaningful.
I want to thank our guest, Dr. Tashuna Albritton, Assistant Medical Professor at the City University of New York. I want to thank our listeners for tuning in. This is Public Health America. I'm your host, Dr. William Latimer. Take care. See you next time.